from New York. Right. Thank you, Florian. Well, thank you for telling us about patient management under radiotherapy and also the prevention of late effects, also the importance of early effects. This is a subject that we will be discussing with very prestigious authors. So we've got Joel Epstein from San Francisco and our friend Mario Lacouture from the Memorial Sloan Kettering Center, who are both experts, very well known in this field. So thank you very much, Florian, for having invited them for this session. Now, I'm going to be very brief since we are running late. We'll talk about the side effects of early radiotherapy, and then I'll hand over to Joel and Mario to tell us about the main early effects, which are essentially cutaneous or on the skin. I'm sharing this with Joel and Mario. Let me set the background to this now. Supportive care during radiotherapy and patient management during the treatment to avoid early effects and also to optimize the use of the treatment. We are not talking about the prevention of late effects, which are certainly more important and which we would like to stop through prevention, new radiotherapy treatments. And these late effects must absolutely be avoided, whereas the early effects have to be managed not by reducing the effectiveness of the therapy. So that is the whole point of this supportive care. So this is really therapeutic optimization, in fact, to get the best treatment. So radiotherapy is used in ballistics, and it's also the use of parallel treatment, chemotherapy, for instance, targeted treatment, and a lot of progress has been made to tell us what the best protocol is. And radiotherapy is a bit like surgery. There's going to be a very precise protocol, which in the long run will give us the right therapeutic result. So when you give just 3/4 of the dose, in fact, you don't get the right results. And then supportive care is really to optimize the treatment and to provide very efficacious treatment, which would not be obstructed by dose reduction or sudden stoppages of the treatment. We all stop a treatment because there's a side effect, but if we remember that the patient is going to lose all chances of being cured, then we'll take a second look at the way we keep stopping the treatment. We all know that an ENT cancer treatment stoppage is really a disaster. So starting with this now, this is where we have better management of early effect management. Now this is standard radiotherapy. This slide is very often shown, particularly at the memorial. And just to tell you that for late effects, you going from 2D to IMRT, we have actually changed this radiation. Now, 15 years later, it is a total change of the patient in regarding quality of life of the patient, thanks to all these new techniques in radiotherapy. Now, you have all sorts of major effects on saliva stimulation, and new techniques like these will add further targeted treatment possibilities, particularly for relapses. There are very few sequels, and we need to absolutely. So now you often have these huge lumps, as you see over here. These are tumors which seem to be non-treatable, but with concomitant radiotherapy and chemotherapy, we have seen in phase 2 studies that with a high radiotherapy, biofraction and so on, and with the CT as well, you can cure 50% of these patients and bring them down to grade 3 when in the past they felt it was not curable. Now you have quite a few side effects, and this is arms A and 3. In arms A and B, you see the grade where it is. It's fairly static, stable. And then the digestive toxicity, etc. So initially these protocols seem to be just for specialized centers, but now you see them everywhere because there is an optimal management of side effects, early side effects, which shows that there's a good compliance of treatment in the patient with fewer adverse events, either early or late. So this idea of supportive care, it includes nutritional support, antalgics with the use of non-steroidal painkillers, antibiotics, anti-vomiting care, local care, as well as maybe low-frequency lasers. Now, what are the limits to this sort of patient management? It's hospitalization of the patient, which is sometimes necessary. Of course, there are alternatives, particularly now that there are service providers coming home to the patient's home, plus the possibility of maybe hospitalization for post-op care. Also, there's better logistic support now. Sometimes there's a problem when patients live far away from the treatment center, but we see that despite this optimal management, there are problems. Patients who stop a treatment because there are other kinds of impacts, or because it's of family life, or they feel that they cannot continue the treatment. So the efficacy is hampered by all this stopping. So you have to handle things like loss of weight, mucitis, epithelitis, febrile neutropenia, secondary infections, and renal failure, metabolic disorders, digestive problems, and larynx edemas. Plus, to all this, we add other problems. As I said, the early effects must be distinguished from late effects. And for non-specialized people, I would say that it's absolutely different effects. There's no correlation between the early and the late effects, and the absence of late effects doesn't mean that there'll be no early effects. And on the other hand, there are several late effects which don't have to have late effects. So we accept them today and we manage them, whereas the late effects, we handle them as best as we can, and we do know that the MTRI does reduce them as much as possible, but not the early effects, because you've got both sides, of these multiple use of rays and so on. So you have to handle the curing, the entire treatment. Joel will speak to us about the importance of knowing the physiopathology of mucositis, which has made a lot of progress today. And today we are testing all sorts of different products which works against this entire gene, NFKB, plus low-frequency lasers that we'll be talking about, these LLTs. And LLTs are used at all different stages of mucositis, and it is used for prevention and for treatment, with an anti-inflammatory effect and antalgic effect, and it helps the scarring to increase. So this treatment is now 15 years old. It exists, and there are several teams who use it. There are guidelines that exist because we have had several phase 3 trials with various uses, with various wavelengths that are used, different kinds of energy, and guidelines today enable us to use laser treatment depending on what we are treating, mucositis, whether it's in intrabuccal or on the outside, with all sorts of different possibilities, particularly transcutaneous effects. So today what we've done, the treatment progress is really the radius of. You give exactly the right dose on the surface that has to be treated, the intensity of this dose, and finally which wavelength for which application. So is it to be intramucous or is it to be just at the skin level? How deep you go in? You have a recognized protocol with recognized guidelines, and with depending on the wavelength, it's either on the surface or it goes in depth. So you have laser diodes which have replaced the other systems, even the LEDs, which are even cheaper. And for epidermitis, the same laser gives excellent results. It is standard treatment today, particularly for skin problems. The protocols, as I said, are well defined. And finally, with all these parallel treatments and specific treatments, we have now a patient who couldn't really accept his disease easily, and we have optimized his treatment, particularly for anti-cancer treatment. We have an improved logistics. We've got improved supportive care, the use of the laser, which helps you to have a global total overall patient management without any interruption of the treatment and also without any late sequels. Thank you very much.